We treat some good 1,400 to 1,500 patients with malignancies per year. And we are with the TrueBeam Linux and now AlignRT, and I'll explain you how we came on that road, because within 2 years we changed the complete infrastructure in our clinic. We were working earlier with Mosaic and Siemens machines, and we had a completely other system for respiratory gating, belt, sensor-based, anti-old system. So this was our greatest motivation. We never used tattoos. Tattoos were never very good accepted by patients. So some of these photos are very old, from the time that even no MLCs were used. And this is really greatest motivation ever to start to make anything without tattoos. So I also show how it looks like today, but this was. We decided that at the first step, we make further the irradiation of breast patients in a deep inspiration, because we were doing that already with another system. But we always had a problem with that. We didn't have any kind of reference. It was like a belt-based system, which was something completely other than a surface-based system, which was to be installed in clinic. Then after the first new Linac was installed at the end of 2017, we decided to take AlignRT system. And also in 2018 came the second machine. We have AlignRT on both machines, and also GateRT on our GateCT, on our CT. So it's kind of pre-training of the patients. Before the patient comes to the first time to a CT appointment, that is very, very important for successful and fast later irradiation. A patient must be willing at the first place, and must be able to hold the breath. I would not now define that exactly on 20 seconds, but must be able to hold that a bit longer, and I'll explain you then later why. A majority of patients accept very good the real-time coach, and they have one impression that they are doing with us, working with us on their therapy. So we were very happy to implement it also. Just a short workflow. We make only one CT scan of a patient. If we irradiate patient in deep inspiration, then the patient gets only the scan in deep inspiration. Inspiration is so deep that the patient can repeat it constantly at the same level, and not so deep that she can never again reach that level when she comes on a Linac. And a real-time coach is also, they are getting introduced with that, so not that it is the first time that they get it in front of their face when they come to Linac. And when the plan is prepared, everything is sent on a Linac. And our first and the most important reference is CT DICOM body contours. And as a physicist, it was very, very important for me that the technologists also understand why is it very important that this CT DICOM body contours remains as a reference till the end. Independent that we are using also reference capture during the irradiation to monitor it. So the most important question was, and that is here, How do we know at all that we have a correct inhalation level during the first patient positioning? We do not have any kind of images. We don't have any more any kind of markers. And how can we know that the patient reached the good level? And then we just agreed that the vertical dish position, table position, has to be something which we use as a reference for our patients. If the table position is on the right position, then I know that if a patient reached this level, that should be this what we expect. Of course, you must know your own table, treatment table, you must know your own procedures, machines, because physicists are checking the table under the big weight and so on, and they know if they need to correct this table position for patients that are, for example, 100 kilos weight or something like that. So, what we use after that for comparison? We use thorax wall, cervical spine, everything what we prepared from our plan also. Diaphragm is very, very important to know if it's a good inhalation level. Then sternum, it's always seen on these images. So once again, I hope that the green lines are good to see. After that, and for us, the images are still the reference, something what is more important for any kind of patient setup. When we make images, we apply normally the longitudinal and the lateral correction if needed. And after that, prepare a reference image if it's necessary. So this is a known image. The irradiation is not being applied until the patient comes within the prepared allowed limits, which are by us 3 millimeter normally. And irradiation is applied if it's less than that. So there is one small video just from the moment to see how it looks like during the irradiation. It's a few seconds only. That's it. So very good is that one can apply different kind of ROIs. I'm not expert for ROIs, but our technologists are. They are applying different kind of ROIs. And it was often at the beginning the question, what happened if there is a swelling of a breast, what we can do not to have under a dosage of a thorax wall or something, then one can just move that part of tissue from the ROI and just look with the images if it's still within the field and irradiate. So why was so important for us to get a AlignRT and to be sure what we are doing? We are not applying the simple homogeneous fields for irradiation of breast. We are working with an integrated boost. For integrated boost, we wanted to get the same low irradiation of a heart and the lungs as we had with normal tangents. That's why we made one kind of a hybrid combined plants, which are combined from static fields and AlignRT fields. And we really need very accurate radiation. So we normally have, from our plants, we normally have about, in deep inspiration, 1.3 average on a heart, and without, it's about 2.5. The highest difference is, of course, on a volume of 30 gray and to heart, which is really, really so huge that one can see what's happening in the moment that we irradiate someone in deep inspiration. This is a very, very known paper, and this can show us that this, what we are doing at the moment, deep inspiration makes difference. It's a nice paper of Carmen Bergom and colleagues, which also gives the data for left anterior descending artery that we are doing also last time. And you cannot protect this artery if you are not irradiate the patient in deep inspiration. Also, the very nice, soft mentioned paper from Derby and colleagues really show us with the statistical numbers what influence has the irradiation of a heart on life of a patient. And this motivates us always to go lower and lower. And we should go lower than 2 gray. So we had this, that's just facts a little bit. We had this at the beginning, and we have this nowadays in combination with AlignRT. I prepared a statistic of more than 2,500 fractions of breast patients set up with markers. So you can see that mostly, it's not a big number, but most of higher differences were in longitudinal and lateral offset. And by AlignRT, we do not have such offsets at all. If you look to number of fractions, I was expecting that with the markers that it will go at lower and lower, but it's not really happening. At least this is what we see from statistics. And by AlignRT, although it's not so obvious, I believe that it's going lower and lower. The same is with the prostate or the pelvis region. The same one you see with the markers, it's completely from day to day, especially if the patients are with more weight. Then this kind of setup is not so secure, and the AlignRT, it looks like much homogeneous. And the same with the number of fractions. So conclusions. We made this statistic just to impress ourselves, to say to ourselves that this system is this what we can believe, and that it makes also, it helps us to exclude the serious potential positioning mistakes. I'll show you just an example. This was the patients that I found just while looking through the database, and is not wrong irradiated because they saw that on the images, but she has 13.7 centimeter, this difference. I was not able to find out if it was from the beginning wrong isometer, or if it isocenter, or if they put false origin at the beginning, what they moved after that, everything irradiated, it's good. But this is something that can never happen if we use AlignRT. The same thing, the same patient, first plan, just with his arms along the body is irradiated. The second plan, while it's VMAT, the arms had to go up, and the colleague just forgot to put it. And so that first on an image, that the arms are there. That could also not happen. Something like that you see on AlignRT. So isocenter was ideal. In addition to patient safety, an additional problem was eventual the time, but the time is going down with using AlignRT. We really reduced our setup time. We developed different checks which told us that we are really safe from a safe side, we and the patient, by using AlignRT. And we see what's happening during the motion tracking of a patient all the time. So we really tried to simplify things maximum, to standardize things, to make everything better through our SOPs and so on. But we must know that nothing should be made simpler as it is, from Albert Einstein. So this is my message, number one, which just make me believe in this. Thank you very much.